You're listening to Nitty Gritty Nursing with Nurse M, where she breaks down the nitty gritty basics of nursing concepts. Okay, and hello everyone. Welcome back to Nitty Gritty Nursing, where we try to break down the tough stuff in nursing and try to make it stick. Okay, today, I think someone was on a neuro content adventure in whatever program they're in. It was another request to do Huntington's disease. And so we're going to try to do the nitty-gritty version of a deep dive into Huntington's disease, which is a condition that, needless to say, is a mouthful and a handful to understand if you ask me, especially as I was trying to prepare the content for this episode. But I did have to do a fair amount of review myself, so let's see how helpful I am for anyone with my drill down on this particular subject. And hopefully we can make Huntington's disease a little bit more simple, clear, and clinically useful. That said, after reviewing everything that I needed to try to piece together, the basic patho background and then the pie presentation being how do these patients present, what interventions do we do, how do we evaluate if what we did worked, and how do we educate. My disclaimer is that this is a devastating disease process that I'm going to go through, and you will quickly figure out as I explain why when I break down the patho of this. But with that, let's get into the pathophysiology. So Huntington's disease is actually a fatal progressive neurodegenerative disorder that is caused by a mutation in the Huntington gene on chromosome 4. And genetically, this is an autosomal dominant gene, meaning that you only need one dominant trait to develop this. And all of that information that I just said means that you have to go back to understanding about DNA strands and the double helix and understanding where chromosome 4 is and knowing that there is a mutation on chromosome 4. So this is passed down genetically. This is not something that someone can just magically get, but it is a genetic trait that is passed down. And it is unfortunately a dominant trait, which means that it's not like a double recessive trait where you have to have, for example, if we're going to classify Huntington's as, a little h. It's not, let's not even do that because I don't want to confuse anyone. But let's say, like someone with blue eyes, because that's fairly recessive, I think. I don't actually know. I'm making this up as I go. But in order for a child with, with the DNA from two biological parents to have blue eyes, right? The mother must provide the child, or the mother must carry at least a little big B or something like that, and the father must carry a little b, big B, or little b, because in order for someone to have blue eyes, if you go back to high school biology, right, you need little b. So if you draw out your Punnett square, right, you can know that if, one parent is bringing in two big capitalized B's and the other parent is bringing in a big B, little b, like there's no chance that the child's going to have blue eyes because there's no way for them to have two recessive little b traits. I say that because when we think about Huntington's, because it is a dominant gene, an autosomal dominant gene, you only need one dominant trait. So if two individuals come together and have a child, in the case of Huntington's disease, right, and we talk about that Punnett square where one DNA contributor has two little h's and the other person brings in and has a big H and a little h, well, that person carrying the big H, right, will develop Huntington's disease, but is not going to show signs and symptoms until middle age. And furthermore, right, potentially, whichever of their offspring have that big H will end up developing Huntington's down the road, right? So it is a dominant trait. Now, what this dominant genetic mutation does is that the mutation causes nerve cells in the brain to gradually break down over time. And this leads to a wide range of symptoms, okay? And the breakdown of those nerve cells, because the brain and every cell in the body is important, right? It really leads to a progressive decline in the person's ability to move, to think, and in their cognitive and mental health. And in that genetic mutation deep dive, for those of you who need this to close that wandering mind gap, okay, this mutation, in essence, right, at the very bottom deep level, leads to an excessive number of what we call CAG repeats in the DNA sequence, and specifically in that Huntington gene, hence the name of Huntington's disease. Now, CAG actually stands for cytosine, adenine, and guanine. And it's this like sequence that repeats CAG, 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 but it has to repeat over 40 times for it to then produce a toxic protein. And this particular protein then builds up in neurons, especially in the basal ganglia and the cerebral cortex, and causes the motor symptoms, cognitive decline, and psychiatric changes that we associate with these patients who develop quote-unquote Huntington's disease. And even more to this point, right, this is why this is complicated, the more repeats of the CAG sequence in the DNA, so the more of that sequence that you have, the earlier the onset of symptoms will be. So if you have 40 CAG repeats, right, you are borderline. If you have 41, you're likely to develop Huntington's. I'm not a genetic person or a genealogist or whatever, so I can't tell you like the cutoff. But if you have 50 or 60 CAG like repeats in that DNA sequence versus 70 or 80 repeats in that DNA sequence, the person who has 70 or 80 repeats will experience signs and symptoms of Huntington's earlier in life than the person that has maybe 40 or 50 repeats. Okay. Here's the deal with Huntington's, the life expectancy after symptoms start. So when individuals start to develop symptoms, what they know from research and looking back in history is that once symptoms start, it is a fairly good estimate that their life expectancy is somewhere between 15 to 18 years. And during that whole time frame, the disease will significantly impact that person's ability to work, to care for themselves, and to maintain relationships. So the really hard part about this, and which is what makes this kind of a sucky topic to have to discuss, is that symptoms typically start to appear in middle age, but that can vary. So unless you have a family member or historically are aware of maybe a family member who has passed that was diagnosed with Huntington's, maybe, this person was adopted, you can throw out any potential. But the potential patients, right, that are going to develop Huntington's are going to start to have symptoms in their middle age. And middle age, I'm going to classify in 30s-ish, right? I'm not going to say a 28-year-old is middle-aged, but I'm not going to say like a 49-year-old is middle-aged because 40 is technically over the hill, so I've learned recently. So what you have to keep in mind is that I'm going to say somewhere in the 30s is potentially when someone will start to develop symptoms. But we also know that usually people who are in their, mid to late 30s, maybe even their early 40s, if they had been dreaming of or had been hoping for having children without knowing that they are a potential dominant carrier of Huntington's disease or the Huntington's mutation, they would have already had children and then, in theory, right, could have passed that trait onto their children without even knowing that they had this fatal neurodegenerative disorder that is progressive. So that's a really sad part, is that unless the family knows or there's some sort of genetic testing that has been done, if someone gets by or doesn't know about their familial history and hasn't had the genetic testing, which in today's day and age is actually quite prevalent, they're in theory that potential to pass that genetic mutation forward to their offspring is quite high. So knowing that it is the dominant autosomal trait that causes this progressive neurodegenerative disorder that results ultimately in death, like it is fatal, Let's talk about how these patients will sort of present, okay? So we know that there are three main areas that symptoms are going to start and that we can assess for from a nursing perspective. And the three primary areas are in the motor, the cognitive, and the psychiatric functions of someone's capacity to live. From the motor perspective, they use a term called chorea, 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 and that is a medical term that is used to describe the involuntary jerky movements of someone. We will also see in the motor category, right, not only the chorea, which is the jerky involuntary movements, but we'll start to see difficulty with balance and coordination. They will start to develop slurred speech and swallowing difficulties. They will also probably develop bradykinesia, which is just a really fancy word that refers to the slowing being brady, and then kinesia being, think kinesthetics of voluntary movements. So their voluntary movements become really slow, and so they are now more slow moving. From a cognitive perspective, what these patients tend to present with out of the gate are some sort of memory problems or learning problems or planning and decision making that is in a decline because the executive function in the brain is starting to decline with those toxic proteins that are being produced that are damaging those cells. And downstream, they end up with memory loss, disorganization. They have really slowed thinking because those connections are not being made nearly as quickly as they once were before those proteins built up enough to cause the symptoms. From a psychiatric perspective, we start to see mood swings, right? Depression, anxiety. They become really irritable and they have personality changes. They're likely to have some sort of potential aggression or apathy. And if we think more broadly, right, we talked about motor, cognitive, and psychiatric decline. From vital signs, right, typically, the vital signs are normal. They're just normal early on. But as they start to progress, right, we're going to monitor for signs of complications in the avenues of motor, cognitive, or psychiatric. So from a motor perspective, right, if we know that they're going to start to develop swallowing difficulties, we want to keep it in our minds that someone who has challenges swallowing has the potential for aspiration pneumonia, right? And so if they develop aspiration pneumonia, then in the line of vital signs, we're looking for maybe they develop a fever, maybe their O2 saturation drops because they have developed pneumonia as a result of the motor decline that led to the swallowing difficulties. Labs, from a laboratory standpoint, right, we can confirm that they have this with some sort of genetic testing because they'll do the genetic testing and they'll actually do the CAG sequence count. If they decide to do any imaging, it's likely of the brain, and all that's going to show, though, is atrophy over the course of time because of the breakdown that is occurring. Now, so that's the presentation. That's how they sort of look. Consider those three big areas, the motor, the cognitive, and the psychiatric components of the breakdown when someone gets this autosomal dominant, right, fatal progressive neuro breakdown trait or disease process. From the interventions, because this is an irreversible and fatal condition, the interventions that we really focus around revolve specifically on prevention of complications. So as they start to lose their ability for the motor component, they become unsteady on their feet, we are bringing in physical therapy for fall precautions. We might be bringing in occupational therapy or speech therapy to sort of help with that motor assistance. We can, of course, give different medications. We can give things like selective serotonin reuptake inhibitors or SSRIs and antipsychotics to kind of help with mood components. We can give them, from a nutrition standpoint, really high-calorie items because if they have the poor ability to swallow effectively, right, what they do take in, we want to, get the biggest bang for our buck, meaning that if they can only, in one sitting, drink 30 milliliters. Well, we want to make sure that every one of those milliliters that they're consuming has the highest caloric content because they need those calories to sustain life. We're doing those swallow evals when it gets really kind of sequential and down the road and they have lost the capacity to effectively swallow because it is progressive. They're never going to get it back. They might put a peg tube in for, tube feedings if needed. And from the mental health perspective, right, that psychiatric, because we know they're going to end up with depression and mood swings and anxiety. I mean, just sit here yourself and imagine that for whatever reason, you end up going to your primary care provider, right? And you said, I've had these terrible problems. Like, I feel like I'm losing my memory. I feel like, I am having challenges with balance and coordination, and my partner has told me that I'm like really irritable and I have a lot of anxiety, and they do the testing and you find out that you have Huntington's disease, right? When you are educated on the fact that this is a progressive fatal disease process, which makes this absolutely horrible, right? From that mental health perspective, what they end up doing is they start to look at suicide screening. They will start to bring in and do family support. They'll bring social work in to make sure that everyone has the support that they need as the disease sort of progresses. And then in terms of evaluation, so those are the interventions. Now, the evaluation and education that we have to give these patients who develop Huntington's disease is we are evaluating, right, whether or not their motor symptoms, they've got that stability, right? Whether or not, like the intervention that we did for mood improvement, maybe that was an antipsychotic of some sort, like did their mood improve or did it not improve? Because if their mood did not improve, then a different approach needs to be considered. If they have swallowing difficulties and we know that they are not getting the oral or the caloric intake that they need in order to maintain whatever their, body physiologic requirements are, did the nutrition or the nutrition approach that we started, did that start to work or did it not? And if it didn't, then you have to revisit each of these sequences in the three primary categories being, again, motor, cognitive, and psychiatric, and really sort of hone and adapt the treatment modalities specific for the patient and the circumstances where they are experiencing this. And we, in terms of evaluation, we want to also make sure that the patient and their loved ones, their family, their spouse, whomever, their significant other, really understand what to expect with this disease process, because it's hard to hear this from a patient perspective, but oftentimes, right, it can also be extremely hard to hear it from a support member's perspective. So with that, we want to then educate. We want to educate on the nature of the disease. I mean, this is not like a tomorrow or next week, like you're no longer going to be able to speak, but we want to educate on, statistically, right? And this is not necessarily going to be you in the nursing role doing this, but if you happen to end up working in some sort of genetic clinic and this is within your work routine, you might be responsible for this. I don't know. As a former ER nurse, these were not discussions I was having, but I could see the potential for that. Even in terms of genetic counseling, to say do you have or have you had children, or they then have to come in and get some genetic counseling and testing as well to see if that particular dominant trait was passed on to their offspring. And if we are giving medications, whether that is for any sort of psychiatric problem or anything, honestly, we need to educate them on the medication side effects. We need to even educate on fall prevention. And that goes back to the basics. We know from a motor perspective that these patients are going to lose their capacity to be able to balance and coordinate their body effectively. And so removing obstacles in their way and helping them and guiding them in the process to prepare where they are living and staying to put them in the best position possible is important. Maybe let's get rid of all of these giant floppy area rugs, because if your feet start to shuffle because you start to lose the capacity to pick your feet up in that motor perspective appropriately, then we are reducing the potential for fall prevention. We also talk to them about advanced directives. That would be something to educate them on, in addition to mental health monitoring and therapy, because it's a lot to have to take in, and we want to be able to support them in that way. This is a deep one. This is a gnarly disease process, and to recap sort of the nitty-gritty aspects specifically for Huntington's disease, it's that it is a genetic progressive brain disorder that is caused by too many CAG repeats on chromosome 4, which is an autosomal dominant trait. It is an autosomal dominant gene mutation. And what it ends up leading to is that buildup of those toxic proteins in the brain, which starts to lead to its breakdown. And it ultimately leads to motor dysfunction, cognitive decline, and psychiatric challenges. And as nurses, our role is crucial, not necessarily in identifying that someone has this, but helping to identify or educate on the potential for symptoms early, on trying to figure out ways to help keep patients safe, to support families, and really to sort of provide really clear education on what they can expect. Because at the end of the day, the more that the patient and or their loved ones and or family have, the more education and knowledge that they have, the more they are empowered to make independent, autonomous decisions about their own medical care. So if this particular podcast on Huntington's disease, if this helped you understand it a little bit more clearly, and you felt like it was beneficial, let me know. Maybe share it with a fellow student if you're in nursing school, or share it with someone that you think that this might be beneficial for. Make sure to subscribe to the podcast if you haven't already done so. I know that it can be fairly intermittent when my episodes come out, because I'm balancing family life, work. But subscribe to make sure that you get some more bite-sized breakdowns on complex diseases or issues. And if you like the podcast, make sure to review it at the very end. There's some stars somewhere probably in the app or the system that you're listening to this in. Feel free to leave me an actual written review. I always appreciate those. And if you have any ideas, feel free to reach out. The email address is listed in the podcast description, and I'm happy to try to tackle it. I can't tackle them all, especially depending on time of life. But until next time, go forth and keep on learning. Thanks for listening to this episode. If you've enjoyed what you've heard or enjoyed listening to these episodes, please make sure to rate and leave a review in the platform you're listening to it in. If you'd like to support the show, check out the podcast description for a link to the Nitty Gritty Nurse shop where you can purchase items. This podcast is meant for education and entertainment purposes only, and is not meant to serve as medical advice. Please consult a qualified healthcare professional for advice. I strive to provide accuracy, but errors may occur, and medications, protocols, and best available evidence may change over time.